The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Collis.
Welcome back to the Knee Guru podcast. I'm your host, Bevan Collis, and today we are excited to have physiotherapist James Kazaglis with us. Sorry, James. James is an APA sports and exercise titled physiotherapist, and he has a strong interest in sporting injuries and exercise prescription. James has worked with teams and players from amateur and professional levels in cricket, AFL and rugby. And James has been working at the Stadium Sports Physiotherapy Clinic in Sydney since 2012. He has been on the research team with Dr. Tom Cross for the cross-bracing protocol from the very beginning of patient number 1, I believe. And he has braced and rehabbed more patients in the cross-bracing protocol probably than anyone else, maybe even on the planet. James is also responsible for writing the physiotherapy protocols that assist physiotherapists like me and others guide people through the cross-bracing protocol. And he's now also presenting to other healthcare professionals on the cross-bracing protocols and what's involved in guiding their patients through it. So if you are a healthcare professional who has an interest in the cross-bracing protocol, or if you are a patient who is weighing up your options for what to do with a new ACL injury, then this episode is going to be especially good for you. So we're going to dig deep and try and find out exactly what it's like to go through this bracing protocol that can seem a bit intimidating at first look. Okay, James, welcome to the podcast.
Thanks, Bevan. Thanks for having me, and thanks for that introduction. Very, very nice of you. So I've been at Stadium Physiotherapy for over 11 years now, and as a clinician, and we see a wide range of things at the stadium. And but over the last few years, we've really have stepped up ACL with the brace protocol. So we've sort of still see a wide range, but the big focus now of the brace protocol, it's been pretty exciting to be part of it.
Yeah, I bet. Something so groundbreaking, and I believe you were there right from the start. Can you tell us how, and briefly how it sort of came to be in those embryonic stages where Tom and Merv started to trial with the early patients on putting them into 90 degrees to facilitate ACL healing?
Yep, so it started around about 9 years ago with the patient 1, where the patient wasn't keen to have surgery. So Tom Cross was consulting the patient and decided to ask Father Merv Cross, as you know, world-renowned orthopaedic surgeon, on other strategies. And he suggested, through his own experience when he was practicing, that often they would find that sometimes the ACL would heal or be quite stable after a period of time. So he suggested, why don't we put her into a 90-degree brace and see if we can approximate the two ends of the ACL and heal it. So that was 9 years ago. And then we had a couple of years later passed again. We had another patient, I think it was Tom's nephew and Merv's grandson, that also a similar process, wasn't keen to have surgery and wanted to explore options. So they repeated that again. And it took a few years to really get started. So the first, 4 or 5 years, it was quite slow. But then I guess word got around and we started to see more and more patients present with ACL who had heard about it. So then we, it really has snowballed. So in the last 2 years, we've gone from, I think around about 300, patient 300 to, again, another, patient 300 about a year ago to another 200 this year. So now over 500 patients have been braced at various stages. So some are back to sport, some are just coming out of the brace now. But we really have seen a big influx, and word has got around. It's gone from initially in Sydney to New Zealand, and with Jane Rooney down to Melbourne. And there's been a couple of scattered around the world as well.
Yep, for sure. You're definitely seeing more and more on it, and getting more and more mass media as well. I saw they did an article on American network television last week that was broadcast around the country. They didn't mention the cross bracing protocol specifically, but it was more around. They did mention the study that was published in the British Journal of Sports Medicine, and more around ACL healing.
So I think it was, I think for years and years, most people thought that you can't heal the ACL. So I guess what we've proven with the research, and I guess there's more to come, which has been led really by initially by Merv Cross, but Tom Cross has done so much work throughout this the process, and now with the researchers of Steph Philbay, and also some really good input from the team down in Melbourne with Jane Rooney. Has seen it sort of really flourish, and it's good to hear the publicity words getting out. So I know Tom's getting inundated with requests and people who are keen to find out more about it and see if they are a candidate for bracing.
Yep. So one of the things I've noticed is that it is quite a polarizing topic in my discussions. I guess I'm talking about ACLs all the time, given the way my life kind of rolls, and a lot of people are really stridently against the cross bracing protocol. A lot of surgeons are still saying, the ACL can't heal. If anything, it binds onto the PCL occasionally, but that's it. Once an ACL is ruptured, it's not going to heal. Other people are very critical of the management of putting people into 90 degrees for a long period of time, saying that it's going to do more harm than good. You're going to get stiffness and contractures and lose strength, possible DVT risk. And so it has been sort of polarizing. Have you had a lot of sort of pushback or criticism that you've had to deal with? And what do you sort of say to those critics who say it's dangerous and that the ACL can't heal, and the risk is too great for the reward?
Yeah, so I think we have seen both sides. I think it's been a well-held belief for years that the ACL couldn't heal. So it's going to take some research and some evidence to prove otherwise. But I think there have been some people who have been very supportive, and there's others, understandably, because it's such a big thing to criticise. But I think we've shown through our initial paper, and I'm sure there's many more papers to come, which will continue to prove it, that you can heal the ACL. Is more than just scarring. It does regrow, and with time, up to 12 months and beyond, it just like an ACL surgery. Where the graft can mature, it continues to mature, has a good blood supply, and you can get really good outcomes back to sport, back to good function, and we find it personally that, or we're finding generally that the patient satisfaction is quite high, that they're quite comfortable with the knee, they're happy with the levels of pain, and in terms of the putting someone at 90 degrees. Initially, that might have been a bit more of an issue because we were quite conservative with our rehab, but now we're starting to challenge it a bit more. And with muscle atrophy, we're finding that when they're coming out of the brace or getting their 12-week scan, that they're pretty much close to symmetry for a lot of people in terms of muscle bulk and strength. There's minimal, if any, knee stiffness, and if it is stiff, it will only be within sort of roughly around 10 degrees off full extension. And they tend to get back that in the next few weeks after they've had that 12-week review. So I don't think it's a big problem. And I think we have shown that it doesn't just scar up, it also doesn't, it can adhere to other parts like the PCL, but it's in rare cases, and majority of the time it heals well. And it does, I guess, what we're showing is that it's not for everyone. So not everyone's a candidate. So there's different gradings, and Tom's been very good in trying to grade them and determine which will do well. And so we're basically filtering the ones which we don't think will heal well. And so they're not normally offered the the protocol, and it's just offered to others who we think are a good chance.
Yeah, it's one of the things I noticed when I was in the clinic there doing a visit a couple of months ago was that this grading of the ACL, and I noticed one of the patients you were seeing who'd been diagnosed as having an ACL, and Tom had looked at the scans, and you'd looked at the patient, and Tom had said, "Oh, we think this is a very minor ACL tear, and we're not even going to brace this girl at all. We think it's going to heal well without any bracing." And I guess at the other end of the spectrum, there's people with high force, high velocity injuries where the ACLs is kind of, blown apart, I guess, to use a layman's term, or reflected, and the stumps out of the intracondyle notch. And those sort of people, I guess, on the other end of the spectrum, Tom will be saying this person's not going to heal, so they're either going to go for surgery or live without an ACL. And I think that's probably part of the bracing protocol a lot of people don't understand. They'd still think of ACL as binary, yes or no. I mean, I used to say to my patients, doing your ACL is like being pregnant. You've either done it or you haven't done it. So it's along with the ACL not being able to heal, it's one of the other misconceptions of the ACL is that it's a binary injury, yes or no. So how does that sort of role in your clinic as far as looking at those scans and determining who gets what management? I guess you're getting better and better at it now.
We're definitely getting better and better at it. I think the way that I and Tom's been great at this, the way that he looks at it is it's like a fracture. So if you have a major fracture, there might be some people who need surgery. They might need to have a open reduction internal fixation or some sort of surgery to rectify it. So that's for the more severe ones. And where less severe might be just, say for a wrist, a fracture might be in a splint or a brace, a cast. So that's the same sort of analogy we use for the ACL, is that some people will have a severe injury, and they're definitely not the ones that are candidates for it. And then some who have a moderate ACL tear, or even an ACL tear which is minor as well, so but definitely still an ACL tear, that are great candidates for it. So when Tom will look at the scans, and he'll determine where they sit in that on that spectrum, that continuum, and offer them to them or not. So it might be so Tom suggested that about 50% of people aren't candidates for it, and so he'll send them to see the surgeon and discuss with the surgeon their options, or go down that conservative path. But for the other 50%, which might be ACL lesion, but on the milder scale, on the medium scale, then they're often the ones which are good candidates for it. So we also then categorise them too. So they've got to make sure that the gap distance between the two stumps aren't too great. So we're looking at a sort of under 4 to 6 millimetre gap distance. That tends to be a good candidate for it. Someone that hasn't had a femoral avulsion off the ACL. Someone who preferably wants someone who has minimal displacement of the fibres, so the fibres could tear and some could, peel off. And we want to make sure that the majority of the ACL is going to reattach and heal. And then finally, we want to make sure they're braced quickly. So within the first 2 weeks, but preferably within the first 7 days. So you want to get the brace on quickly. So not everyone, in summary, not everyone's a candidate. And but those that are candidates, we're getting better at selecting the ones which will do well. And we're finding that our results are getting better and better each time.
Yeah. And this is really terrific for the patients who are, fortunate enough to be walking through the door of the Stadium Sports Clinic and assuming they're living in Sydney. But what about for patients around the world who don't have access to someone like Tom Cross, who's such an expert at reading the MRIs, because most MRIs reports you'll see will still be quite binary or lacking a lot of detail in the description of the ACL rupture. And I know this is an area that Tom sees as critical for the future of ACL management, is this MRI report reading, how many sort of radiologists or doctors or even physios are there around who can read these MRIs with enough detail to decide on the chance of healing and choose an appropriate management course?
Yeah, so I guess Tom can't see everyone, and he's doing his best to see as many people as possible and classify them. And he's got systems in place to try and classify and get to as many people as possible. And there are more and more radiologists and whether it's sports physicians who are starting to adopt it. But that's probably the big challenge, I think, going forwards is we need to, and Tom's onto this now, is trying to train up as many people, particularly medical practitioners, to be able to classify and also manage the person through the ACL protocol. So it is a challenge to go ahead, but I think we are starting to make inroads. But I think that as a patient overseas, I don't think we're quite there yet to be able to handle the volume of them. But we're hoping that what we can set up is, I guess, a network in various parts around the world where we have a radiologist, whether it's sports physician or surgeon, and a physiotherapist working together with the patient to classify the patient's ACL injury, and then to appropriately medically manage them, and then, of course, to rehab them too. So hopefully over the next few years we can expand it.
Yep, for sure. So one of the things that I found interesting in my discussions with Tom was that he was saying that the number one sport that he sees with ACLs is skiing. And of course, with my background, with my clinics in the ski fields, we're seeing skiers who've injured their ACL every day, often several times a day. And Tom was saying that often those low impact ski injuries where, sometimes the patient hasn't been, or the skier hasn't been going fast, and they just catch an edge and the ski didn't release, and because of the torsion, bang, the ACL pops. It's a very common sort of low force mechanism of injury, and Tom sort of, still anecdotal, but he sort of believes those low force ACLs tend to be the ones that will do well with the cross bracing protocol. But if you contrast that to a pro skier who's jumping off a 15-meter cliff and lands the wrong way, and their knee kind of gets blown apart with multi-ligament injuries, or just a really high force, high volume traumatic knee injury, those are the ones that won't heal. Have you noticed any sort of away from the MRIs, any of the clinical signs that are going to predict if somebody's ACL is likely to heal or not?
I think really it does come down to the initial MRI, and so making sure that we have a good MRI completed. But I totally agree that the high velocity, the probabilities of causing more trauma to the knee, and in particularly the ACL, two ACL stumps separating even further, the chances are going to be a lot higher than compared to a low velocity injury. So there are some people who have higher velocities, injuries which still can be braced appropriately, but majority, the lower to medium velocity, you tend to have less trauma. But it is a tricky one because as a clinician, it is hard to. There's no sort of physical signs we can see externally. We do rely predominantly on the MRI to classify them. So maybe something we might look into, or we are always looking into, but we might sort of have a breakthrough in that regard. But I still think that the MRI really is the what we rely mostly on.
100%. So do you think there's any correlation if somebody's got a really swollen knee with a high force velocity compared to somebody whose knee's not very swollen and the injury was low force, that there is or have you been surprised many times with, say, a low force, low swelling, low pain type presentation, but then you find out that the stumps are quite far away and that they're actually a low chance of achieving a good heal? Have you noticed that you've been surprised a few times? Or
yeah, there's definitely surprises with some of the gradings which you'd think from the initial injury, the way they present. But I guess it also is the other injuries, whether it's the MCL injured as well, whether it's meniscus damage as well. So there's other factors, I guess, which would sort of confound the presentation when you do see them. So yeah, it is definitely a tricky one. So yes, I guess.
Yep. All right. Well, hopefully we can get, and one of the things we're working towards this ski season for our Japan patients is getting a list of radiologists and sports physicians who are able to read these scans to the right, so they're not we're not all relying on Tom Cross's expertise. All right. So if a patient is listening to this and they've ruptured their ACL in the last few days and they're tossing up, whether to go into the cross bracing protocol, it's a little bit intimidating thinking about living your life with your knee bent at 90 degrees for at least 4 weeks and then being unable to walk. If it's your right leg, you can't drive. Might even put some people out of work depending on their job. It's a little bit intimidating, but what sort of can you walk us through, or walk that person through what's going to be involved? What are they in for over the next 4 to 6 weeks if they decide that they're going to go through the cross bracing protocol?
Yeah. So I think part of the initial process is just considerations of what you need to achieve, whether you need to drive, need to work, whether you have the family support. I think family support's a big part of it. So having someone there which could help you carry things and get you to and from appointments. So I think you do need a big support base. But those that have find that they can manage that, and people who have no support that can get through too. But obviously, the more support helps. The first 2 weeks, I think, are the toughest. You are, locked down. Your routine's thrown out. You've something foreign. You've got a brace on your knee, which is there 24 hours, 7 days a week. So it is quite daunting and hard to get used to. But we find it, generally speaking, getting a routine going. You will get used to the brace. You'll learn how to, and we often teach people how to just shower with a shower chair, pillows for sleeping. We recommend, if you can, getting a scooter to get you around places. There's also an eye walk, which is another way of getting around without crutches. So trying to have systems in place, and also try and find a good routine for yourself. But it does get better, and each week you will find the routine's good. The pain will go away pretty quickly. That's the beauty of this, is that most patients aren't in much pain at all. They tend to tolerate it really well. So getting through the first few weeks, but then also the light at the end of the tunnel. Once you get through that couple of weeks, then you know that in 2 weeks' time you're going to start to straighten the brace out, and so we know that each week then we'll start to progress and get you back to walking by about the 9th week. So if you can really to sort of get through that initial stage, and also we often say that people trying to be as social as possible, try and get out, do things. There's many examples of patients going to concerts and going out for dinner and seeing friends. So try and stay connected. It makes the process a lot easier.
And are patients using wheelchairs through this period, that they're locked at 90 degrees, or is it mostly the knee scooters or the eye walk that you talked about? It's kind of like for people who haven't heard of it, it's almost like a pirate leg with your shin on a shelf sort of thing, with this pirate leg coming out below. What are people finding is the easiest, or are people just using crutches and having their knee bent up, hanging in the air? What are the people finding is the most convenient and common way to get around?
I think most people find crutches still the best method, particularly for short trips. So whether it's the forearm crutches or the underarm crutches. And some people learn how to sort of hop around their place a little bit too. But then if you want to sort of explore and you have and you know that there'd be a flat environment, then definitely the scooter is a really good way to get around, and you'll be a lot faster than everyone else getting around. So it does make things easier. You can achieve a lot more. You have something to store shopping or whatever you're out for. So the scooter is definitely a really good suggestion. But majority of people just go with crutches, and we are seeing more people trying the iWalk. I think that's a nice way of just freeing your hands to be able to and walk more normally. And as Bevan said, it is like a peg leg, but it does work well. And once you get that routine, it is quite helpful too. So try and find out which methods works best for you. But still, we're finding the crutches the main way people get around.
And just how fragile, I guess it's speculating a little bit, but how fragile do you think that those stumps of the ACL joining together are? Like if somebody has a moment of kind of a brain fade and has the brace off for a minute while they're showering and just puts their leg out straight for a second, do you feel that it's that healing can be totally undone just in a little moment of leg extension? Or do you feel like I put my knee back at 90 degrees and all's not lost? I guess it's hard for you to know exactly what's going on, but do you educate the patients that it is really fragile and you really need to be 100% compliant and not straightening the leg out at all if you want to get a good heal?
Yeah. So I think as a patient, you do have to be 100% compliant. We're not too sure how strong when the fibers start to reattach, how strong they are. So we do get the system set up so that the patient is not a situation where it can straighten out. So for instance, in a shower, they will put the chair up against the wall there so they can't extend the leg out. But I guess there's probably a little bit of a wiggle in a few degrees, but we try and make sure that they don't extend it out because it could compromise it and probably will compromise it, particularly in the early stages, particularly in that first 4 weeks when we're not too sure how strong it is. So, but again, I think as long as the patients understand what they're getting themselves into, they tend to have no problems at all. So we haven't really had many issues with that in the 400 to 500 people who have got through that stage. Of anyone really compromising it. Very rarely will that happen. It'd be normally under special circumstances. And then in terms of confidence with falls, we find that most people if their brace is on, they're fine. So we've had many people who unfortunately have tripped over, fell over, been knocked over, but we find that once the brace is on, that their ACL heals really well. So it's really just trying to minimise that extension, so not straighten the leg out. And again, a lot of people are worried about sleep at night and thinking, what happens if in the middle of the night I wake up? The brace is quite good and quite strong. So we don't have much of an issue there with that.
So what are your sort of advice for people as far as wearing the brace? Should they be wearing it 24/7 and just take it off to shower and that's it basically? Apart from that, they've got it on all day, every day?
No, we've over the last year or so, we have become a little bit more lenient. Initially, my suggestion would be just to loosen a strap at a time of your brace and get the circulation going. But now we're finding that if you back yourself and you're a trustworthy patient, you're not going to straighten it out, and you're sitting at home and just want a short period of time, sitting down on a chair, and you know that no one's around, no one's going to knock you, then we do have people take their brace off for a bit. So it is, yes, 24 hours, 7 days a week, but that's at 90 degrees. So as long as you can maintain that, we don't mind people either loosening straps or taking off for very short periods of time. And again, just have those systems there, so there's something blocking you. If you do think of something else and something else happens, you have something there to block the knee from straightening out.
Yeah, I guess intuitively, it kind of makes sense for a fracture. If you've got a broken bone and you've got a little bit of wiggle in between the bones, everybody's going to be super careful to make sure those bones don't shift away from one another. But it's a little bit more of a obtuse concept when it's a soft tissue inside your body that you can't see and you can't really feel whether it's healing or moving or not. How have you found that sort of buy-in from patients? I guess how are you educating patients about that importance and about the healing process and about how the stumps meet and how they might how the healing might be upset?
Yeah. So I think one of the tough things as a patient is that there's no real way of telling whether the ACL is healing. So we feel lots of questions along the way. So and we often just reassure that as long as the brace is at 90 degrees, it will be healing. We've got the research to back that up. But there's no other external signs. And so whether it's pain or stiffness or something else, they might be saying, is this a good sign or a bad sign? Unfortunately, we don't know until we do that MRI at the 12-week period whether it's worked or not. And again, we're finding great results at 95% plus that that it's healing. So we know it's going to heal if you do the right sets, but there's no sort of again, those external cues to indicate whether it's healing or not, and whether it's a good thing or a bad thing.
Yep. And so as far as attending physiotherapy while they're in the brace and while they're going through the 12-week protocol, how often are people coming, and what sort of things are you doing during the consult for those people? It sounds like you're getting great results with with a pretty remarkable maintenance of range of motion and strength at the end of 12 weeks. I'm sure most people will be surprised to hear at what sort of high level of function you're reporting people coming out. How are you achieving that, and what are you actually doing?
Yeah, so if I run through the typical, probably from the start, often Tom will bring the patient in and we'll put the brace on day one. And so we'll put them at 90 degrees and we'll run through the exercises and some management strategies of, again, the sleeping and the showering and crutch use. And then we'll give them some exercises to start with, so some basics, just to, some quads strengthening, some bit of calf movement to minimise the chance of DVTs. And then they'll come back weekly from then on. And we find that weekly does work well because often the brace can migrate. So they'll come in this, after 1 week, and we'll have to adjust the brace slightly. We'll then add more home exercises, so give them quite a big program. And we often might do some, as physios, do some massage, manual therapy, and then we often encourage them and we'll take them into the gym and get them started. So from that first or second consult, we're in a gym doing some pretty I think pretty heavy stuff in terms of leg press, calf raise, and hamstring curls. So trying to get the muscles going. So we're onto it early. Where if we rewound sort of 3 or 4 years ago, we were very conservative. We were trying to ensure that the ACL healed, and so our exercises were very basic. We'll just do some activation, some ankle plantar flexion, dorsiflexion, so getting the ankle moving for DVTs again, minimisation. So we've gone from that very conservative with a primary aim of healing the ACL and a very distant aim of minimising atrophy and bone mineral density losses to now a more I think a more comprehensive program trying to load the knee up so that they can minimise muscle atrophy, minimise bone mineral density loss, keep the meniscus and the joint under load. And then therefore we're finding that when we get them into those later stages, when they start walking, they've already experienced lots of weight-bearing exercise and strengthening exercises. And then again, when we come to that 12-week review, we're now finding that where we used to have, for instance, a quads circumference difference of 4 or 5 centimetres, we're now getting to that sort of 1 or 2 centimetres, and often it's symmetry for a lot of patients who, I guess, is probably partly their training background in that, but who have worked really hard, who've managed to get the symmetry at the end, and it's not just the muscle, it's also the knee range of motion and the function, so they're walking quite well.
So obviously, there's growing evidence that it's the 90-degree range of motion that facilitates the healing. How damaging do you think the weight bearing or force going through the foot or through the lower limb can be to healing? Do you feel like you can load it up to 100%, and as long as the knee is kept at 90 degrees, it's not going to affect the healing at all? Or do you feel like you have to be a little bit careful with how much force you're putting through the whole limb?
Yeah, so another good question. I think we still have to be careful about how much load we put through it, and so we set this the ceiling at about body weight. So so therefore we do wall squats, which are body weight or half body weight. You put weight through the other leg. We do leg press or leg press isometrics at sort of body weight. So we do have a ceiling on it. We may change that as time goes on, but at this stage we're sort of left it at that level. But that's normally enough to keep things going. It's also often patients still, particularly in those early few weeks, are still pain from the injury itself. So
Yes.
that might be a limiting factor as well. But we're trying to encourage them to load as much as possible up to body weight.
So that would be the whole body weight through one limb, through the injured limb you would go up to?
Through two legs. So I guess it's half your body weight. So we will put the leg press at if they're a 90 or I'd say 70 kilo person, we'll put the leg press set at 70 kilos. So for both legs. So we don't tend to go above that. And I think we're not too sure how much we can load it. And we have loaded some above that weight, but again, it's how confident we are that and they've healed well. But as the challenge of the process is that we often with the protocol is that we don't really know until the 12-week mark. So if we load them up, we're still waiting potentially up to 12 weeks before we know whether that new exercise or that extra load had an effect. So there's always going to be a lag. There's always going to be concern about it, whether it has an effect. So we're very conservative on starting the conservative side of things. And that's why I think it has taken, 9 years to get to where we are, because we've been trying to be as careful as possible to heal that ACL. But we're definitely now at a rate now where we feel very happy with our rehab and the process that we're getting, really good results in terms of strength.
Terrific. And what about DVT risks? One of the criticisms is the increased risk of DVTs and a possible association with the pulmonary embolism and the extreme risks involved there. So what are you doing for your patients to prevent DVT risks, particularly for our patients who are possibly flying home from Japan or Europe or North America after doing an ACL on a ski holiday? I guess they've got that acute risk, but then also that probably continues throughout the whole period of non-weight bearing and even longer. So how are you managing those risks, and what advice would you have for people?
Yeah, so I guess it's definitely been a concern particularly from the start about DVT risks. And so from pretty early stages, we've anticoagulated everyone who's been at 90 degrees, and that's a key part of it. So for those who are thinking about just putting themselves in a brace at 90 degrees and then potentially coming back home, we definitely don't recommend that because you need anticoagulation. There is a DVT risk, but as long as we're anticoagulated and we do the exercises, we haven't had any issues with DVTs over the last few years, and even initially as well too. So we try and minimise the risk through anticoagulation and exercise. And there's definitely an increased risk if they are travelling, coming back from a ski trip. So we recommend now people to go to 30-90. So from 30 degrees off extension to 90 degrees flexion if they are considering being braced. And then so that means they can keep walking, they can keep moving, and it will reduce the chance of a DVT. And then once we get them appropriately assessed and graded and sort of they got that informed consent about the whole process, then we'll put them at 90 degrees. And often the best way to also do that is to combine it with a Doppler scan, so an ultrasound scan to check at the initial stages where there's a DVT, but also along the way we're often, or initially we were scanning a lot through Doppler to see if there's any DVTs, but with anticoagulation, the risks are minimal.
Yep. That's exactly what we started doing last year when we started to understand that extension was not a good position for recently ruptured ACL. And I don't know if you've been skiing in Japan, but generally the footpaths and roads over there are pretty difficult to navigate on one leg. So there's snow everywhere, and everything's very slippery, and it's quite a extreme, dangerous sort of environment. So we've been putting them in at 30 to 90, and this year we're trying to get the word out amongst the community to that key period in between sort of 5 to 20 days is when your chance of heal can be totally scuppered, I guess. And as physios, it kind of goes against what we do, because we tend to think, right, let's get the person moving, let's get the knee straight, let's load the person up and prevent stiffness and prevent muscle loss. So you've done your ACL, okay, well, let's get you straight and get you moving so that you're not going to lose. So it's a little bit counterintuitive, particularly for us physiotherapists, I guess. But we've really just got to educate the patients and probably readjust our own thinking a little bit. Has that been a difficult process for you to go through as a physiotherapist, to kind of go against that impulse of getting people moving and getting people sort of active?
Yeah, absolutely. I think we do want to get them moving. We do want to reduce whatever the deficits they are, whether it's range of motion or strength. So we're often being trained to do the opposite. But I guess with that fracture analogy, to think of it as a fracture, as a fracture of the ligament, like you would with a casting, you need to immobilize it for a period of time to allow it to heal appropriately, and then that's when really I think physio's in a great position there to load them back up again and get all those deficits, which unfortunately you do get. Again, we're minimising them through a more aggressive protocol over the last year or so, but there's still going to be deficits there, and that's when we have to sort of put our physio caps back on again and get them loaded back up again.
Yep. And as far as the patient profile, you were saying before, it's not for everyone, and maybe 50% of people that have ruptured their ACL, you decide aren't good candidates. Who do you think it is a good candidate for? Is it can children do it, for instance, or do you think it's going to make its way into elite sports? Is there a faster pathway to return to sport? I know there's a broad sort of question, but what sort of who's your ideal candidate, would you say, for the cross bracing protocol as far as their age and lifestyle and whatnot?
Yeah, so I think in summary, everyone is potentially a candidate. I guess it's down to the injury itself, the severity, the time to brace, and then the gap distance. But we do find that kids are great candidates because often they haven't had their growth plates fused yet. So having surgery, poses a risk there too. So I have patients. I think maybe the youngest is 9, but I've got one currently who's 11, and a few 12 and 13-year-olds who are sort of getting through. And I think they're great candidates because you can heal their ACL, you can get them back into their sport, and it does take surgery does take a big mental toll, I think, on kids and also adults too. So without the pain that you find through surgery, that we tend to find that their quality of life is better and their outcomes are better. Yes, it's not easy to be in a brace for 4 weeks and at any age, particularly a child who's an active child, but we do find that they do tend to catch up pretty quickly and often overtake the ACL surgery patients. So everyone is a candidate. The challenge, I think, is in the professional athlete. I think that's one we've had a few that have gone through, but there's lots of variables. There's lots of inputs from managers and coaches and clubs, and I think they want to see more evidence before they start to put their patients through the cross bracing protocol. So I think that will come with time. But at the moment, I think as I said, we have some elite athletes for various circumstances who don't want to have surgery, who have gone through it and done really well. But I think majority are those who aren't the elite athletes and not professionals. Aren't professional athletes. The elite athletes we definitely think are candidates, and definitely the children are really a great, I think, opportunity then to brace them and I think prevent them going through, I think, a pretty tough process of surgery.
Yep. And what about the return to sport time? Sort of cross-bracing protocol versus surgery versus no bracing and no surgery. How long are people getting back to ball sports after the cross-bracing protocol, are you finding?
Yeah. So in summary, it's still 12 months, just like and beyond, just like surgery. We have had people initially who we managed to get back earlier, but we feel that, like again with surgery, where the ACL graft will mature, we do think there's a process of maturation for the graft. It gets stronger each month. So instead of getting like maybe before at 9 months, we sort of have now suggested that they wait beyond that 12-month period to get them back. So they are on par with surgery. And anecdotally, through what I've found is that they tend to be better performing, I think, at that stage, and it's a matter of just sort of holding them back for that ACL to heal. And the deficits are often long gone. The asymmetries, the strength deficits, the power deficits are often addressed a lot earlier than they would with surgery, because I think surgery is often quite painful for patients. They're often having issues even down, months down the track with loading the knee up again too. So some are fine, but as a generalization, I think the cross bracing protocol tend to do quite well.
Yep. It's one of the things you always reminded of when you see a patient come in on their first appointment post surgery. Just what a big trauma it is for the knee. People sort of blasé about it, or some people are excited to get their surgery or see it as kind of a sexy pathway to take, I guess, because that's what the pros will do. But when you have a look at what it does to the knee and what a big trauma it is, you're kind of reminded, okay, the surgery is no joke. And talking to Stephanie Philbay, she's saying the studies showing that there's inflammatory cytokines found in the knee up to 5 years post surgery, that people probably forget what a significant secondary trauma surgery is. But one of the criticisms that I've heard just talking to other healthcare professionals is that they feel that the healed ACL is still going to be on a stretch, and with the ACL OAS, the healing classification system, there's not enough people from the cross-bracing protocol getting a fully healed ACL, and that the surgically replaced ACL or even repaired will be stronger. We know that the angle of the tunnels that the surgeons drill, without getting too technical, can really adversely affect the effectiveness of even a surgically replaced ACL. So there's no guarantee that the surgically replaced ACL is going to be as good as the original. In fact, it's very likely not to be because of the double bundled structure. But what would you say to those people who say, your surgery replaced ACL is going to be stronger and more stable long term than one that's healed with a little bit of laxity in it?
Yeah, so first of all, I think surgery has a very important part in ACL surgeries. In ACL recovery. Or an injury. Yep. So I'm still very much in favour of surgery for certain populations, and also for certain populations in favour of conservative, whether they can't be braced and going down the path of just rehabbing the knee and getting back to sport that way. So I just feel that there's an option there for certain people who I think are good candidates for it, and who want to go down a path of being braced. We think that if you are braced, you're more likely to have a better success than conservatively. You tend to have better outcome measures if you do have an ACL. In comparison to surgery, I often think about it. What Merv Cross said to many and to myself is that your own ligaments better than your hamstring or your patella. So we feel that once you can heal the ACL, they can come back together. With time, as it matures, it does get stronger, and in comparison to surgery, I think we're on par in terms of obviously with surgery there's re-injuries, and ACL brace protocols is going to be re-injuries as well, but we're on par, if not slightly better at this stage compared to those that had surgery. So we think we're holding up very well, and I think the better we can identify the right candidates for it and then put them through the protocol, the better outcomes they'll get. And we do feel that the ACL ligament is strong and continues to heal, and it's part of your own DNA, I guess, part of your body, which I think will hold up quite well.
Yep. Okay. And one of the other criticisms is that the study's only the published study so far. I mean, the published has been studied only on the first 80, and now you're up over 500. So it's a pretty significant number you're up to. But it is only a case series. You don't have a control group, so a lot of people can be a little bit dismissive or saying we need to be very, very cautious in recommending this to our patients, which is true of any new management that comes on. What's ahead? Is there? I hear whispers that there is a plan for a randomized control trial. Can you let us know what's in the works there?
Yeah, so I think that'll be led by Steph Philbay, and also Tom Cross and Jane Rooney and others who've, I guess, lead the research component. So there is plans to do further research, and I think I'm an evidence-based practitioner, so I'm keen to get as much evidence as possible, make sure it's and analyse it. So we are aware that we are, this is early days. We're just starting out, so we had to go through the process of a case series. But with time, we'll get stronger and stronger evidence. We're very confident where we sit, but I think there's always going to be people who want to see more evidence, which I think it's great, because I think you need to see more evidence. But we're confident in what we have already. But again, with a randomised controlled trial, hopefully getting started soon, or something very similar starting very soon, that we can give the results that people need to see what we're seeing anecdotally and what we're seeing in the clinic day to day.
And just sort of finishing up now, what do you sort of see, looking in your crystal ball, for the next 5, 10, 15 years ahead in ACL management? Where do you think the cross-bracing protocol is going to sit in? Do you think it'll, I guess some critics will say it's a fad, that it's just going to die out because it's too difficult and to go through, and surgery is an easier option, or not conservative management's an easier option. There's some people who are quite still skeptical about how important the ACL is, and think that people can do terrific without an ACL, and the surgery and the cross-bracing protocols are overkill. What do you sort of see ahead for how does a cross-bracing protocol going to fit into ACL management in the years ahead, do you think?
Yeah, so I think the way I see it is that an individualised, I guess, patient-centred sort of treatment option, where they could potentially go to a surgeon, and a surgeon would say there are, at this stage, 3 options. You can go through surgery, you can go through conservatively without having surgery and trying to rehab it that way, or there's another option, which is through the cross-bracing protocol. So giving the patient an option, whether it's through a surgeon, sports medicine practitioner, giving them the option to say that it's not just you need surgery only. There's only one option, surgery, or no surgery. But there's a third option. So I feel that with, again, more evidence, we've got 500 coming through now, and more quality research to come, that I think we'll get to a stage where that will be an option on the table. And I think patients are starting to ask others, whether it's a sports medicine practitioner or surgeons, are there other options? And I think we're very confident in the results we're getting so far, and I'm sure we'll continue to have that. The cross-bracing protocol will be a very good option for patients who have had an ACL injury.
Yep. Okay, that's terrific, James. Thanks very much for your time. If patients out there have recently ruptured their ACL and they wanted to get in touch with you or with Tom Cross, how is it there at the Stadium Clinic? Are you guys totally snowed under and booked out for weeks, or can people get an appointment face-to-face, or can they get a telehealth appointment with Tom Cross or have him look at their scans? Are you still sort of accepting new patients there, either remotely or through telehealth or in person?
Yeah, so we're still accepting patients. And what we often do is we go through the Stadium Clinic, through the reception staff there, who would often get an email or contact through a patient. So if you want to contact Stadium Clinic at Moore Park in Sydney, and then present the, hopefully you have an MRI, or you can organise an MRI quickly, and then we can sort of classify you. Then from then on, we're hoping that Tom will be able to suggest whether you are a candidate or not for the bracing protocol. And if you do live in Sydney and can see Tom, then great. He's seeing patients. He's taken a step back and he's purely working on the ACL brace protocol. So he's no longer seeing patients for general injuries and sporting injuries. So he's devoted all his time to this, and he works countless hours to try and see as many people and help out as many people. And in terms of physiotherapy, we've had many physios who are all trained and see many. We've got a really good team here who continue to develop the program and improve it all the time. So there's opportunity there to come and see us. But if that's difficult, if you're just outside of Sydney or outside the area, we are training other physios through running a course we did a few weeks ago to train other physios to show them what we do, and make sure that there are other opportunities to see others outside of our clinic.
Terrific. Okay, that's been great. Thanks very much for your time, James. I'm sure that podcast will be a real gem for anyone that is particularly healthcare professionals who are interested in this area, but also and particularly for patients who are trying to get their head around what to do with their ACL. I'm sure they'll find that really invaluable information that you've given over the last hour. So thank you very much for your time, James. And any other parting advice for those people who might be sitting there who've recently ruptured their ACL in the last few days?
Well, first of all, thank you. Thanks for having me today. I think quickly, get onto it quickly. Make sure we get the MRI done quickly. You can get in contact with whether it's someone who may be doing it locally, or the Stadium Clinic. But time is important. So we definitely want to see people within that first week, but it can extend out a little bit more than that. But yeah, the quicker you get in, the quicker you get onto it, the better.
Terrific. I think that's a great note to end on. Don't delay. The clock's ticking every minute after you've ruptured your ACL while that healing window's open. So that's great. Thanks very much for your time, James, and a pleasure to have you on.
Thank you, Bevan. Thank you.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myokokogen.